Now, if we can invite all the panelists to join us, and I'll try as best as I can to manage the questions. If we don't get through all of them, we will endeavour to get back an answer to everybody. And I'm going to start with one for Professor Dorian Haskard to do with international figures. And I'll then move on to Desmond, sorry, wrong, and Graham Wallace to do with research and international research, because they're slightly linked, those questions. So, have we got everyone, all the medical panel up yet? I can't quite see.
Somehow my video is not working.
Okay, well, don't worry. Have a go.
You can hear me.
Yes, I can hear you. That's fine. Great. So, Professor Dorian Haskard, could you just give us a quick update on sort of international patients, how they've been, one suffering perhaps from how many cases from COVID, which has been answered by one of the patients, which would be great.
Well, thank you, Tony. Can you hear me?
Yep.
Well, I think that our communications with via the International Society, I mean, clearly, what is not clear is actually what the impact of having Behçet's is on the degree of susceptibility to COVID. I think that there is a big unanswered question there. What we're proposing to do is actually to convene a meeting, probably early next year, where we're going to have a webinar to actually get experiences from around the international community, to try and get something a bit more than just anecdotal evidence. I think at the moment it's really difficult to say. I mean, there are reasons to think that Behçet's patients may be more susceptible, but equally well, there are reasons to think they could be less susceptible. So I think we just don't know.
Great. Okay, thank you for that, Dorian. Graham, Tessa had asked a question about, is there any international research going on with the Netherlands? Could you just give us a bit of an overview from your side of? I know you do quite a lot of this work.
Yeah. So we've got a couple of projects looking across the globe. One is with the Netherlands and with Italy, and we've got some funding from the Behçet Society, from which we're very grateful. And that was to look at gut microbiomes. So the three groups involved have all got microbiome data, but as often happens, the particular species of bacteria alter depending on which country you're looking at. So the plan that we're going to do there with the samples were going to be sent from our colleagues in Holland and in Italy to us in Birmingham, and we were going to do all the preparation and the analysis here, just to see whether there's something to do with the way in which samples are processed as opposed to what's happening in each country. The other piece of work, that's obviously been held up by COVID as well, about getting samples. But the other piece of work that we're still working through is a study that we've been doing with colleagues in the Middle East, and that's been looking at whole genome sequencing of patients with Behçet's disease, and also from the same individuals, we've got serum and urine metabolomic data as well. And we're now linking that together, again, with genome studies that have been done across the globe. There are some genes that seem to come up in all populations of Behçet's patients, but others may be specific to different regions. So we're looking at that and see whether that will actually be shown up in metabolite profiles as well. So we had a Zoom meeting about that this week, about processing the data, and that's ongoing.
Brilliant. Thank you, Graham, for that. That's really, really good to hear. And thank you for all your research support, which most Behçet's members from the UK are well aware of. I've got one for Dr. Desmond Kidd now. What medication options are suggested after failing Remicide, infliximab? What treatment options are suggested for neuro-Behçet's?
Oh, well, so Infliximab works very well for neurological Behçet. Most patients respond well to it. Most patients do not relapse whilst taking it. And the main issue with using infliximab is the prevalence of the development of antibodies to infliximab. We're trying to work out why this is. There's another population of patients that I deal with who also receive infliximab, who develop antibodies much less frequently than the Behçet population does. It may be something to do with the degree of immunosuppression that is provided and the way in which they receive steroids as well. But if those patients need to switch from infliximab, because the antibody level reduces the amount of infliximab available to their body and therefore their brain, so therefore the drug stops working, then we find that we can switch to other drugs, also TNF-alpha drugs like adalimumab, or Humira is the other name for it. And there are other papers published which show that drugs like golimumab, for example, possibly also etanercept as well, also work quite nicely. If there's a problem with an allergy to all of these forms of treatment, then we do have some information that other biological drugs work well. Rituximab is a different kind of biological agent. There are 3 or 4 papers suggesting that it does provoke benefits in the neurological aspects of the disease. And then there are reports also of the IL-6 blocker, which is called tocilizumab, which I'm not sure that we have available to us in the English Health Service, but it does provoke substantial benefits in certain subgroups of neurological involvement, particularly those which are caused by vasculitis, which is the inflammation in the blood vessels, which can sometimes affect the body and very rarely also the brain. So in summary, most people do very well with infliximab. It's usually not a problem, but we do have many other things as a safety net to use should patients not be able to continue with that drug.
Thank you very much indeed for that comprehensive answer. That was very useful, I'm sure, for everybody. Could I welcome Suzanne? Dr. Suzanne Crozier. She very helpfully stepped in last night at short notice because Steve couldn't make it. And within some of the questions we've had before, an underlying theme is the difficulty of the sort of psychological aspects of Behçet's. So I wonder if you just would like to give any of your thoughts on this at the moment, Susanna.
Yeah, in general, relating to the psychological effects. Yeah. So, I mean, I think obviously within I've read some of the talks today, and I think chronic pain and fatigue has kind of been mentioned as quite a theme in terms of common, feature of Behçet's, and I think that's certainly something that comes up regularly in clinic for myself in conversations that I have with patients about the syndrome. And I guess to say, obviously at the moment with the current context of COVID as well, in terms of increased anxiety and about, an impact on quality of life as well, would be kind of more current concerns. So I guess in terms of encouraging patients to access psychological support via the centres as well. So we're offering remote consultations since the start of the pandemic. So hopefully shouldn't be too much of an interruption in that sense to access to psychological support through the centres, and access to primary care mental health services as well. Quite a lot of areas have set up additional support that's been specific around the pandemic as well. So encouraging patients to access support via their GPs if there's changes that in mental health that have been related to the COVID-19 epidemic as well, pandemic. I don't know if there's anything else more specific in terms of the questions.
No, that's helpful to start off. In fact, we'll come generally, I'll ask all the panelists to do with fatigue. We have a lot of questions about fatigue, and my question will be on that, is to what we need to, how are we going to go about addressing this? How can the society help the clinicians with surveys or whatever else, and research and stuff? I'm just going to ask also Professor Phil Murray, who hasn't been seen probably by anybody yet. Would you like to just give some general guidance about if people ever have issues with their eyes? I know it's from a layman's perspective, if you have issues with eyes, you need to do things quickly.
Certainly. Hi there, everybody. Yes, well, just to say what's been happening with us during the pandemic and the centre. So as far as ophthalmology has been concerned, we've still been seeing patients. It's not the greatest specialty to do virtual consultations either by telephone or video related. So we've been, anybody who's had flare-ups or problems, we've been seeing them face to face, which is a problem also to us because we get very close to our patients. So we're worried about our own health. If there is a problem, if there is a flare, then and you're under a centre, please contact the centre, and you will be. I'm sure you will be seen. I'm sure the same thing will happen anywhere else. We're all attached to big units, and we have accident and emergency departments anyway, but I'm sure the clinic will see the patients. We have access in Birmingham, we have uveitis clinics running every day of the week, and there are a number of consultants, some that will do the Behçet service and some won't, but there'll still be connections between all of us, and we will be able to see the patient. So there should be no issue, certainly in Birmingham.
Thank you very much, Phil, for that. That's really useful to know. I'm just gonna, there's a couple I've seen here, 2 or 3 on diet. Here's one. Is there any strong evidence for simple dietary changes that can ease mouth and genital ulcers? Can you please talk, what role does nutrition play in the frequency and severity of flares? What nutrition recommendations do you have for patients? So does anyone want to answer that one?
Well, I could probably give it a bit of a go. I think the bottom line, I mean, Farida has done some work on this, and there's been some other information come out from our colleagues in France looking at various types of food. The bottom line with a lot of the dietary elements of in relation to any disease is still not particularly clear. I think there's no doubt that the broader your diet is, the better it is. That will almost certainly help. So the idea of looking at things like having lots of fruit and veg and fibre is present there. But it's part of the reason why we're doing the microbiome studies, to see whether there is any indication within the microbiomes that could be driving some of the features of Behçet, and whether that can be altered with diet. But the whole system around nutrition is, in relation specifically to elements of disease, is actually not at all clear yet. And unfortunately, it seems to vary between individuals. So again, it's not particularly definitive, but I think the important thing would be to have as healthy a diet as possible, which will help the body in all sorts of other ways. And then, you know, we'll hopefully in a few years' time be able to say something a bit more definitive about what foods may help in these circumstances. But, you know, we're looking at, I mean, the gut microbiome has been looked at in virtually all diseases. Diet has been looked at in all sorts of different conditions, and there's no clear pattern coming out yet.
Great, thank you, Graham, for that overview. That's really useful. Let's turn now then to the question that are quite popular, so submitted for the medical advisory panel. In straw polls in online groups, people with Behçet's often cite fatigue as the symptom that is most detrimental to their quality of life. So could we just have a sort of group discussion about any thoughts on that, please, and where we might go with it?
So perhaps maybe I'll start, Tony. It's Rob here from Liverpool. best part of the meeting for me, the medical panel. Sad I can't meet up with my friends on the panel, but also I seem to get asked all the challenging questions that we can't really answer. And I think fatigue, but also pain, is one of the key unmet needs that we see at the moment. It's interesting, we've heard from Farida Fortune that quite a few years ago, it would be ulceration that was a major thing. And I think with the centres, with our increased knowledge and our better treatments, those are not quite as bad. I think fatigue and pain have always been issues, but because we're better at addressing other things, these are the things that we're not able to address. Why not? I think it's because we just don't really understand it. We can measure a whole variety of things in the blood that normally can be related to fatigue, such as thyroid problems or anemia or inflammation. But our patients with Behçet's don't have abnormalities there. There's something different that's driving it. And it's the same with pain. In pain, we set up a big study in Liverpool to try and understand what the nature of this is. And I think we need to be doing the same thing with fatigue, because the drugs that we treat Behçet's, even the fancy designer drug biologics, often don't affect fatigue at all. So it's very challenging for me as a doctor to have a patient telling me about their profound fatigue and me feeling that there is really very little in the way of options that we've got at the moment. So my answer is we don't know, but we jolly well need to learn.
I come in. Hello.
Frida, yeah, brilliant. Thank you, Rob. Yeah, yeah, Frida.
Hello. Can you see me? Yeah.
Yes.
Okay. Fatigue is a real problem. And what I'd wanted to say previously in my introduction, it's really important for everyone to work together. And so with our European partners, with the International Behçet's Association, I think with all the patients. So if you look at almost, I know some work had been done previously on other chronic diseases, and fatigue is always thrown up. But there isn't actually any research at the moment looking at fatigue in any meaningful way. So again, with the Behçet's Society, Richard West and I've worked with a huge organization looking at AI, and using artificial intelligence had identified some molecules. And so I think that that's really quite important. We've done some preliminary work showing the interrelationship between fatigue and how fatigue, and sleep are driven by different processes, how they interlink and one feeds off the other. But I think it's really important to put a lot more emphasis on research with fatigue as well. And then just to add to what Graham was saying about diet, there's been lots and lots of work, and ever since we set up the centres, we've been collecting patients' diets. I now have a nutritionist doing her PhD on diet, and the way we collect data is actually not useful. So she's analysed all the data, and as Graham says, there's no relationship when you look at components of diet. Sometimes in families it's important, in ethnic groups it's important, but you can't find anything that there's a commonality. So again, I think in diet we need more research, in fatigue we need more research, in sleep pattern we need more research. And as Rob says, as we've done more and more work about the other physical symptoms that impact on quality of life, the patient surveys, which are crucially important, and actually now with the patient-reported outcomes and the surveys have shown that these pain and fatigue are really important, and that diet makes a huge difference to patients.
Thank you, Farida. That's most helpful. In fact, interesting, I noticed a question here from Hannah Parker, and it says, is there any way Behçet's UK could develop an online calendar or app or IT system where patients could easily record their symptoms on a daily basis? If you could add separate family members, i.e. your children too, so that they could monitor the occurrence of ulcers to see whether they think they're beginning to get them and all that sort of stuff. So interestingly, I will start off with that. Fianna in Northern Ireland alerted me to an app that a community is using over there. And I do believe if we could have some way of developing that, it might assist us to record data in sort of real time. It does create a burden on the patients themselves, but if they're willing to do it, I think it's a very strong way probably of gaining information. So I don't know whether you would agree with that, Farida.
I do, but because I think patient-reported outcomes are hugely important, and we started moving our research to patient-driven outcomes. I think they're really important, and in 2009 the survey was so important. We had enough information from it to go to the commissioners for funding of the centres, and the health economics behind it cannot be underestimated, because I think we constantly have to prove ourselves that we are efficient within the NHS. And this year, the health economics, simply just from our centre, and I'm sure it'll be exactly the same across the centres, again shows that we are extremely efficient at doing that. So to go back to your question, I would say patient-reported outcomes are important. I think sometimes we have patients who collect their symptoms on a daily basis. What you want to see is the pattern, because it's a huge burden. With something like Behçet's, we have huge amounts of symptoms to collect them continuously.
Brilliant, thank you, Farida. Now I'm trying to find a question here, which was related to if you've had COVID, and it was, and I can't now find it unfortunately, but basically it was saying, is there a risk if you've had COVID and got over it that you can then give it to somebody else? That's the gist of it. Anyone like to throw any thoughts on that?
I think that's the big question that everybody's looking at. The question of, you know, you've got some individuals who they're positive when you do the DNA test, but they don't have antibodies. So the antibody test isn't necessarily picking up everybody who's positive. Question, I think, of how long people remain positive even after they've got a test is not that clear either. And I don't think there's necessarily been enough follow-up study for that. I think clearly if you do get a positive test, then you isolate and, you know, try to keep away from people as much as possible. But there seems to be several patterns out there of antibody positivity, infectiousness, and so forth. And even being positive with antibodies, we're not sure how many of those people are actually infectious.
Thank you, Graham. Brill. Quick question here. How long TNF take to act? That's from Mamata. Who would like to throw?
Very quickly, in almost all situations. That's one of the reasons that we give infliximab as the one TNF inhibitor that's given by intravenous infusion. If you give an intravenous infusion of infliximab, you get major high levels in the blood very quickly, and patients can feel a benefit very fast. The other TNF inhibitors are injectable under the skin. They can work really fast, but one of the reasons we like infliximab, particularly people with eye disease or brain disease, is that the very rapid onset of action. Although whenever we do give something, we'd often give a covering dose of steroids, which is not a long-term treatment, but just something to buy time for the other drug to be working.
Thanks, Rob. One from Laura Forrest here. Behçet's in children. Flu vaccine, should they have the nasal drops, live vaccine, or a range injection? What about for BD patients who have children, What about for BD patients who have children offered the vaccine to? Which should their child have?
Shall I come? Yeah.
Yep.
Okay. So flu vaccine is always offered to children intranasally. So it's done at schools. I think it's under the age of 2 years that it's not recommended, but the group we would be working with our children, it would be, and it's recommended for intranasal.
Thank you, Farida. Right, let me just see what other ones I can get here. Right.
Tony, could I make a comment?
Yes, Deva, actually, thank you. You've been commenting online a lot too, so thank you very much for doing that, Deva. Yes.
I mean, just wanted to go back a little bit to the fatigue, because we were saying how much we didn't know about what we should recommend to patients, but it is important that there are some sort of principles that I think are relevant for patients. First of all, as Farida mentioned, I think sleep hygiene is crucial. So all the standard advice that we give to our patients to ensure optimal sleep hygiene is important. Obviously, when we have got patients who've got active disease, we do often see improvements in their symptoms when we control that, their disease activity effectively with medication, as Rob has said. But the other thing that I think we perhaps need to focus on is I think Rachel mentioned how good she felt when she went on and did some regular exercise and gradually built that up. And I think it's important to avoid getting into the scenario where you get deconditioning, which can occur sort of imperceptibly over time when people feel ill for a long period of time with a chronic relapsing and remitting disease. So working out a way for you that's good for you to gradually build up your levels of regular activity will be important, because what your body often tells you when you're ill is something counterintuitive. It will ask you to keep resting, but what you find is if you keep doing that, you'll actually feel worse rather than better. So those are the things that I tend to generally advise my patients to do above and beyond anything more specific that we might have for them in the future.
Thank you, Deva. I picked one out here that was submitted in advance. Behçet's, especially juvenile rheumatoid arthritis and hypermobility, are these symptoms of Behçet's often misdiagnosed? That's how the question is phrased.
I think that's a hard one to answer, I think, really. This is something where there's really a specialised secondary care service with typically paediatric rheumatology. We do know that there's a significant number of children with Behçet syndrome, and Claire Payne from Liverpool is just completing and about to publish the survey that we've been doing that's been identifying that together with Farida and other colleagues as well. So it's certainly around in children. Certainly it's far less prevalent than juvenile idiopathic arthritis, but what we're finding is that most paediatric rheumatologists, which is the type of consultant and team that will be seeing these patients, are able to be thinking of a diagnosis of Behçet's and should be in a position to think, is this a standard JIA picture, or should it be referred to one of the centres of excellence looking for Behçet syndrome? So there is a bit of an overlap, but I think we should be in a position in paediatrics to be able to highlight and think about and refer on, if appropriate, Behçet's.
Brill, thanks. Now, in fact, there's a related one here. It keeps jumping. Oh dear. It's to do with genetics, but when people are up voting, it moves around. Oh, where's it gone? It was basically saying what work is going on the genetic side to investigate. I'll see if I can find out.
Well, while we're waiting for Graham to collect his thoughts and I'm sure definitively answer this question, I can see him smiling there. I was reading stuff the other day and I was really excited because Michael Ombrello and Elaine Remmer's group, who've done a lot of the work in America to look at the genetics of Behçet's disease and unravel some of that, have published some further work which looked at a sort of overlap of the genetics between recurrent aphthous ulcers and another syndrome that we often have difficulty in discriminating patients with Behçet's with, called Fabry syndrome, which often we've got several patients that come to our clinic who present with fever, mouth ulcers, lymphadenopathy, meningism, and sometimes have eye problems. And basically what they found, interestingly, was that the genes that associate or are in the mix for Behçet's disease, some of those markers can also be found amongst the population of patients who have the Fabry syndrome. And in fact, there are fewer of them, but still some of them in common in the patients who have recurrent aphthous ulcers too. And they've coined the term a sort of Behçet spectrum disorders as a result in their paper, and indicating that these patients are sort of on an overlap in terms of genetics. And it's fascinating to read their papers in detail and see how each of the papers that have been written on this seem to indicate that they're pointing towards an underlying commonality between them. So I found that fascinating, and I'm sure that that will lead to further work in that area.
Yes, thank you, Deva. I found the question now. Are the genetics of families being examined at present? Question mark. Have met families with 2 or 3 generations with Behçet who would be willing to be involved, but not sure where this begins. Behçet Centres of Excellence, or through the charity and those patient-led registries, or are there international findings already? And perhaps if I would start that off, because this is one of the issues that confronted me 3 years ago, because of the way things have been established with the membership and things, we don't know how many families have it at the moment. And then you have issues like GDPR and this, that, and the other. And hence the whole business of patient registries, so you can get all this stuff logged down. And then, as Farida was saying, then you have the sort of quality of life issues that come in routinely done. The question about monitoring symptoms, fatigue, and all that, producing the evidence. But specifically with genetics. So, Graham, did you want to add a little bit to what?
I think we discussed this a little bit during questions last year, and it was something that we were thinking of taking on and should take on. The general consensus is that Behçet's is not a hereditary disease. It doesn't necessarily run in families. And certainly every time I say that at the Congress, there's at least 2 or 3 families in the audience that say, well, I've got it, my daughter's got it, and so forth. It is something that we need to follow up. It's not something that we hear about from other countries particularly, but it may be for the exactly same reasons, Tony, that people don't really check it and don't ask for it. The families can be extremely helpful in looking at genetic profiles of what's happening. And yes, I think it is something that we need to identify how many families are involved, and to get the samples from those individuals so that we can start to look at some genetics. I think the other thing I would say, and it's related to what Deva just mentioned from Mike Umbrello's data, what we also find with conditions like Behçet's is that within families, you may have other individuals who've got other similar sorts of diseases. It can be like juvenile arthritis, it can be Crohn's, it can be other autoimmune, autoinflammatory conditions. And that's because the majority of them do tend to run with the same genes. So genes involved in producing cytokines like TNF, which we block in Behçet's and in lots of other diseases. So there's a general underlying element of the inflammation that's going on in lots of diseases, which is why we pick up the same genes, and also the fact that it runs in families. But looking at families specifically for Behçet's would give us things over and above that, and help to try and tease out some of the other elements that are going on.
Dorian, you had a...
Yes, Tony. I mean, there is a simple point that I think is perhaps worth making, which is that any heritability of Behçet's is not going to be like Tay-Sachs, which we were hearing about earlier. So we're not talking about a single gene. We're talking about a cluster of genes. It's a bit like being given a bad hand in a card game. It's a cluster of genes, and for that reason, you need to have very big numbers of samples, numbers of patients, and that's best achieved with international studies. Families are helpful, but the numbers involved now are thousands rather than tens. So you need to have very, very big consortia to sort this out, and that's only sorted out now with the help of information technology, which can help crunch the numbers.
Thank you, Dorian. Very useful comments there, yeah. Now, I'm conscious we did run over, but I asked Victor, who kindly said we're allowed to run over, and our attendees are still up in the 89. So, but I think we probably need to draw it to a close. What I will do, though, I'll ask you all just to give each one of you any final thoughts you've got, any advice or anything, if you wish to. And then I'll give a vote of thanks at the end. And what we will try to do, everyone who's listening in, we'll go through the questions and make sure we get an answer for you. Within them, I've noticed there have been answers actually given, but we haven't necessarily ticked them all off as answered live specifically. So I don't know, does anyone want to say anything anything further at this stage? If so, John.
Perhaps I could just very quickly say something. It's Rob here. I'd like to thank you, Tony, for organising a fantastic remote Behçet Day. I think, from my perspective, this has worked really, really well, not least because I could have my wedding anniversary at home. But I particularly want to thank patients for all of the questions. So as physicians, clinical psychologists, scientists, we really want to be hearing your questions, because it's not what we think that's important, it's what you think and what you want. So you've got to be telling us, you've got to be holding us to account. We're better than we were yesterday, but we want to be better still tomorrow. So it really depends upon you to be telling us and helping us so that we can be helping you. Thanks. Thanks,
Rob. And we'll definitely promulgate all the questions and the answers so that we get back, yeah.
Just one final point on fatigue. I think one of the things that makes it very complicated is that fatigue is part of the inflammatory process. If you're looking at an acute situation, say you've got a flu, and in the past you'd feel really bad for 48 hours, you'd be tired to go to bed. And the element of fatigue is to make sure that you're not expending energy on anything other than the immune system to try and deal with the challenge. That works very well for the acute situation. But obviously, when it becomes a chronic inflammatory situation, you've got that persistent message. And I think that we may need to break this cycle in some way. We may need to look at possible epigenetic changes that have been made in the pathways that are leading to fatigue. And that's something that's going to be something for the future, but we really need to have a look at. Try and separate out. We can control the inflammation, but we're still getting the fatigue.
Okay. Next on my screen, Deva, how about you?
Well, I mean, it's tempting to become very depressed at this time of COVID, and I think one of the fantastic things that's come through as a flavour from your meeting that you've organised, Tony, is that how optimistic this time is in the longer term with the science, and I think it showed great foresight to put in the data science side. From Mendelium and from Will to show how in the future we can get much smarter with all the data that we have in the system already. And as Dorian has said, with larger numbers, I think it gives an incredibly powerful tool to dissect out the patients with Behçet's who present earlier, and also to see the patients that are rarer that look like Behçet's but actually don't have Behçet's but have some other a condition that looks like Behçet's, but in fact the genetics is different, and that's where the families can help us too. So I'm really excited at this time with this sort of coming together of the data science, artificial intelligence, and the genetics and epigenetics, that we'll actually be able to unravel a lot more and get better at treating and diagnosing patients.
Thank you, Deva. And Suzanne, Deva sort of touched on the sort of psychological side there, booster morale and all that sort of stuff. Ex-army, I'm all into that. So would you like to say something?
Yeah, just on the issue of pain and fatigue as well, thinking about the psychological impacts of those parts of the condition, and there are psychological approaches and psychological therapies which have got evidence for impacting on pain and fatigue. So not actually reducing pain and fatigue necessarily, but thinking about the psychological and impact on people's lives living with those parts of the condition. So that is something that psychology can play a part in addressing with patients as well. So you know, would encourage people to access those psychological therapies as well, which can help with the impact of living with pain and fatigue.
Thank you. And I would just emphasise that John Mather and the team at the Behçet Patient Centre are very much into this positive approach. We see it in the newsletters, and it's really good work. So thank you, John, for all that. Desmond, I was just going to sort of related, would you like to just make any comments? Certainly one I've noticed a couple of patients are having difficulty with getting fusion now, partly because of COVID things. So I don't know whether there's any specific issues there that can be resolved.
I didn't quite hear that. Did you say that there are some patients having difficulty getting infusions?
Yes, I saw one patient contact me to say they were having difficulty with getting infusions. So, but I know another one who visited another centre. She normally visits one place, but now she visited Bristol. That was another one. So,
well, there shouldn't be any difficulty getting infusions. We haven't got any data which suggests that continuing biological treatment renders any infection with COVID more severe, for example. It is something we have to be very careful with, and where we give the infusions have to be, you know, proper ultra clean areas. And so we do encourage people to continue with their treatment. I do have a couple of patients who've chosen not to. What happens is that their condition obviously has tendency to relapse, and we're monitoring that very carefully. There's another treatment that only I'm giving, which is plasma exchange. And I wonder whether or not your correspondent is referring to this. Plasma exchange is given to a small number of people with certain kinds of neurological manifestations in Behçet syndrome, not regular neurobehçet disease. There are different subtypes that I'm happy to talk about some other time if people want to know. We found the plasma exchange works very well for that. Problem with plasma exchange is that it's a very good dialysis machine, so all of the plasma exchange machines have been removed to intensive care, and so it stands to reason that we can't really continue with plasma exchange except in emergencies. And so some of my patients have been able to gain access to it. I've been trying to get them fitted in all over the country because my own hospital is being particularly difficult about the treatment continuing. But we are trying to get as many people continuing as we can. Plasma exchange is something which the NHS is looking at in detail at the moment, and there are plans afoot to change the way that people can gain access to plasma exchange, which is problematic in this situation, because it means then that they say, well, we've got to wait for the working group to work out where all these centres are going to be and where the funding is and everything else, and that means that we can't do anything to make a decision about existing patients at the moment. So it's a problem from that point of view. But happily, infusions with infliximab and with steroids and other immune suppressions should be continuing. And I think we'd all, sure everyone else would agree that we should all encourage patients to continue their treatment during the pandemic.
Thank you, Desmond. You've corrected the word I used incorrectly. It was mixing up both infusion and plasma. So well done, you. Thanks. That's exactly what it was. Phil, anything from you?
No, just really to emphasize what you commented on before, is that if you have an eye flare-up, please, you do not need to be seen, and you will be seen.
Brill. And then we've got Priyanka, Will and Farida. So who wants to go next? Priyanka, how about you?
Hi. Okay. Yes. Thanks, Tony. So I just wanted to say thank you to you and everyone who's helped in organising it, and also to the patients who've given up their time to attend today. And just want to echo the other speakers' sentiments that actually, you know, we do need to learn a lot more and be better tomorrow than we are today. I think we struggle as well as, you know, as clinicians as well, to often diagnose this very heterogeneous condition, which I think someone has asked on the question, does it overlap with inflammatory bowel disease? Well, it absolutely does. And you know, the hardest thing actually from our point of view as clinicians is to tell someone they don't have Behçet's often, but not be able to quite explain why they are still getting symptoms, and that's frustrating both for patients and for us. But hopefully the more research we can do, the better we will be at diagnosing and treating this. So yeah, thank you for all your support.
And thank you for picking that up. Yeah, Gemma alerted me there are quite a few bowel-related questions that may be worth acknowledging. Yeah, and will be answered. Yeah, so thank you for that. Will.
Yeah, thank you, Tony. And I just want to say, you know, thank you for a great meeting. Fascinating to hear from all the other speakers. You know, this is a disease I'm possibly the least familiar with of everybody sitting on this whole Zoom call, but it's interesting to hear so many parallels with my experience being the chair of another patient advocacy group. And you know, I think one of the things to say is I think an important thing I would just mention is that one of the features and why actually Behçet's I think does lend itself from a diagnostic point of view to these kind of electronic health record driven approaches is because actually in fact it needs to be a clinical diagnosis, because these are clinical features. You haven't got a single gene test, so as a consequence there is much better than many other diseases that we look at published criteria which have been validated, and people have done regression models to prove it and compare it with control populations. So you know, I do something to think if this is an area that you wanted to expand the diagnosis of rare diseases using electronic approaches, a hugely valuable thing is for people to have already done what has already happened in the Behçet community and looking at those, you know, the associations of different clinical features with the diseases. So I'd compliment the whole community on that.
Brilliant, thank you, Will. And I have noted to the directors that you are keen, or Mendelin are keen, to make sure that they get the expert opinion so that anything that's not right in the models can be corrected. So I think we'll have some interchange of views there, so that'd be brilliant. And so Farida, last but not least.
Thank you very much for last. Thank you very much. Firstly, to the patients for all the data, and when they come to clinics, collecting a huge amount of data from them, it does make a difference. Clinically, research-wise, and for a whole load of other reasons. But another point I would like to make is, can we continue to be international? I know we're doing a lot of UK-based guidelines. In fact, all our patients are the same across the world. And Dorian Haskard has led the EULAR guidelines, and there was a huge UK contingent doing that. Again, with the genetics, we need huge groups to be able to then dissect out the overlap syndromes. There has been a lot of genetics, but with small numbers, for instance, showing there's sharing of genes between certain types of Crohn's and Behçet's as well. But I do think that the centers are amazing because we all work together. But besides that, we have to work, unfortunately, I hope we don't drop out of the European Rare Disease Network, which we might, and we have access to a huge platform in Europe where everyone puts queries on. And then the International Behçet Society, or Behçet International, which drives research you know, across the world. Whatever numbers we have here, they are still really small, and we need large numbers to get valid outcomes, because it's not a gene-specific disease. It's really heterogeneous. I mean, 40% of the patients coming to my clinic now don't have Behçet, because oral ulceration occurs in 25% of the population. And of those 25% of the population, a minute amount will be Behçet. There are at 70 different diseases that will have oral ulceration. So large numbers if we're going to get anything meaningful. And thank you, everyone. And thank you, Tony. It was a really good idea of yours, and it's worked really well.
Great. Thank you, Farida, for those final comments. And I would just obviously back that up because we have some comments online about sort of UK focus, which this has to be. That's what our charter says to start with. But rather like Japan benefited from having a register which their government produced, and they then discovered that the symptoms were moving from eyes to the gut. That's the sort of thing that we may discover when we get our population really squared away with the register. That's my view. And as you quite rightly said, Farida, that's got to link in with the international community as well. So I'm definitely a collegiate on that side. Right, so thank you very much, everyone, for today.